All right, I am now recording this, so we're going to go ahead and start. I'm going to go ahead and mute everybody, um, and and then I would also ask: is anybody on a phone and not on a computer? Could you just give me your name if you're on a phone and not a computer? You won't be able to see the slides and get the full impact, but I would like to record that you're here. Okay, I've taken that as nobody's on a phone, everybody's on their computer, so we have about 16 attendees.
I think it's because you muted everybody.
No, I haven't muted everybody yet.
We have two callers besides myself.
Two phone callers?
I'm on the phone. Brian.
Okay, waiting for names. All right.
I'm actually on my phone and my computer, so I'm listening to you on my phone, but I've got the computer up and running too.
Okay.
Doug.
All right.
Yeah, I'm doing the same. This is Steve.
All right. Okay. Well, let's go ahead and get started here. First of all, before we start, this is a big commitment. Let me mute everybody here and make sure you can hear me.
Looks like criminal proceedings have been concluded and indefinitely postponed. So that means the trial's been canceled. Which means that Alex took a plea, which means that Alex is in prison.
Okay. Hold on. How do I mute everybody here?
Not correct.
This isn't the beginning.
Holy cow.
No, you declared war on the last minute. We're ready to slow down, and now you're selling troops before he even.
All right. Now, there's two things that we're trying to do here tonight. One of the things that we're trying to do is we're trying to get a information to you all so that the sales call that you're going to make is going to be better and can be more effective. And the second thing we're going to do is try to reinterest you in generating some targets and go out in the next week or two to make some sales calls and to see what the general level of interest is in this Calcanail, because we have some highly differentiated products here. Now, for all of those who are on this, there is a Dropbox where you can look at the presentation that Michael has and get at that, the information that Janet sent out. What I would like you to do is, after this webinar, is fill out the test that's on it and email the test back to me. And my email is g.sherburn@fhortho.com. Now, for those of you who send that in to me, and I'll check them over, and if you get 80% and give me 3 target names on that sheet, I'll send you a $10 gift card from Starbucks, so your next coffee or your latte is on us. So, but I would like everybody's participation in that. We're really wanting to test the water with sales calls here. So now let me go ahead. Hey, I'm sorry, Derek, could I ask you to mute your speaker there?
Sure, let me see.
Yeah, just hit the little green button up at the top there.
The green button.
Where the microphone at the top.
It still says it's connecting the audio for me for some reason.
Okay. All right. Well, we'll figure this out.
Here, I can. I'll play around with it. I'll see if I can.
Okay. Michael, I'm going to go ahead and turn it over to you for the meeting. So go ahead.
Okay. Cool. Okay. You all can see my screen. The hyperlink that Janet gave you should have taken you into a folder in Dropbox, and in that folder there should have been 3 items: the PowerPoint presentation that I'm going to go over, a recently published paper that I'm going to go over, and then the quiz that Greg has indicated that he'd like for you to take afterwards. I promise you, if you pay attention to this webinar, you'll ace this quiz and you'll be drinking nice coffee. Okay, so I imagine this will take much less than an hour. Okay, so we're going to talk about Calcanail, and this is a compilation of surgical tips and tricks as a result of the many cases that we've done so far. I'm also going to go over a recently published paper, and I'm going to give you some other sales tools. Point 1. You should know that Calcanail is an excellent solution for patients who are elderly or diabetic or smokers. The reason, normally, when you're doing an ORIF, open reduction internal fixation, you have to wait 5 to 10 days for the swelling to go down so that you don't put undue stress on the surrounding tissue and get a wound dehiscence. We don't have that with Calcanail because we're making 4, 5, or 6 percutaneous stab incisions. We're not making that big lateral extensile flap. So this is a perfect procedure for the elderly, the diabetic, or the smoker. And then also equally important, you don't have to delay this surgery waiting for the tissue swelling to go down. And since you don't have to delay the surgery, the ability to move the fragments back into their anatomical position is much easier because they've not become knitted in place as a result of the normal delay. Calcanail is a technique that's minimally invasive. It's resulted in 0 lateral skin necrosis in our published papers, even in the elderly or the diabetic or the smoking patient population. ORIF procedures cannot make that statement. So compared to results which have been presented at a meeting in May of 2012 in a poster, take a look at our results with no lateral skin necrosis compared to 22% of patients who had wound healing problems. And of those 22% of the patients, 38% of them were in smokers, 13% were in non-smokers, 63% were in open fractures, 14% in closed fractures. We don't have that problem, and we can take all comers. So in the first published paper that we have, I talked about a group of over 70. The doctors, Mario Goldbach and Patrick Simone, they stratified the patients by age. So in this graph here on the right, this bar chart, the first 3 columns, let's see, this first 3 columns are time frame 3 months. The next 3 columns are time frame 6 months follow-up. And then the last 3 columns on the right are time frame 12 months follow-up. Now I know many of you might not be able to read French. Moins de 60 ans means less than 60 years old. The next group that I'm circling here, entre 60 ans et 70 ans, means between 60 and 70 years old. And then the third group is more than 70. And then these 3 groups repeat themselves for 6 months and for 12 months. And the green represents the alignment score that you can get from the American Orthopedic Foot and Ankle Society scoring system. The purple represents the function score, and then the blue represents the pain score. So if we look at the patients that are less, so I'm just going to focus on the results at 12 months follow-up, which is the last 3 columns on the right. If we look at the patients that are less than 60 years old, the average score was 89 points. So 9.76 plus 45.24 plus 34 equals 89 points. If we look at this next group between 60 and 70, their average score was 80.6 at 12 months. And then if we look at the group over 70 years old, they actually did the best. They had a score of 93. So this is just confirmation that Calcanail is for all age groups, even the elderly. Point 2. Why do we use a distractor? We use it for several reasons. One is to create space at the subtalar joint so that we can reduce the fragments up against the talar surface using the inferior surface of the talus as our template to push the fragments up against and put them back into their anatomical position. Distraction also does another thing. So when we distract between the talus and the calcaneus, we create axial compression between the medial and lateral walls of the calcaneus due to something in orthopedics that's called ligamentotaxis. We also benefit from tendon taxis. It's a mechanism that facilitates reduction of the lateral wall. So we take advantage of the ligaments and tendons that are still intact and still attached to the bony fragments. Let me show you how this works. So ligamentotaxis, what is it? It's an orthopedic surgery technique of using continuous longitudinal force, a fancy name for distraction, in order to bring fracture fragments more closely together. It's what's used as a temporary measure in the management of a broken bone. It's the basis for the use of an external fixator in an unstable distal long bone fracture. So by applying this distraction force, the soft tissue surrounding the fracture help mold the bony fragments and facilitate the reduction. So this is not taxis, it's taxis. So what are the ligaments that are involved when we do a distraction of the subtalar joint? We got the talocalcaneal ligament, which is made up of 5 branches. There's a lateral branch, there's a medial branch, there's a posterior branch, there's an anterior branch, and then there's an interosseous branch. And then we also take advantage of the calcaneofibular ligament on the lateral side of the ankle. The tendons that are involved are the flexus hallucis longus on the medial side and the peroneal tendons on the lateral side. When we use this distractor, as pictured here, the ideal position of the distractor is with the bar side up. However, if it gets in the way of the alignment rod used for placing the screws, then just turn it around so the bar side is down. I have found most often in subtalar arthrodesis that I benefit from the bar side down. Point 4. You have 2 positions that are recommended for doing a calcaneal fracture with calcaneal. Lateral or prone. Prone means the patient's lying on their stomach. So just as a point of reference, Dr. Goldzak always uses the lateral position. Professor Simone goes prone for his bilateral fractures. I think that's what everybody will likely do for bilateral fractures. He'll also use prone for an arthrodesis, and he'll go lateral for the unilateral fractures. But there's some key points here that can really make your case go well or badly. And this is a key point, to take the time to position the patient properly before you even scrub the patient and before you even drape the C-arm. So if you're using a lateral position, it's helpful to have the foot extend beyond the edge of the surgical table so that the C-arm can easily be maneuvered in and out, and so that you can get the axial view and the lateral view that you need. So, for example, on this picture here on the left, it's absolutely necessary that the foot be off the edge of the bed because the C-arm can't get underneath the bed, like it can here in this middle picture, or like it can here on this far right picture. So depending on the size of your C-arm and where you have obstructions on the bed will facilitate how you need to position the patient. And you should just check before you drape the C-arm and before you scrub the patient, just check that you can rotate that foot so that you can get the desired axial, retrotibial, and lateral images. Once you've confirmed that, then go ahead and drape the C-arm and scrub the patient. So after we place the first pin with the olive in the calcaneal tuberosity, we have to place a second pin that's perpendicular to the first pin. The position of this second pin depends on the type of fracture. In the case of a depression fracture, which I'm showing here marked by the blue arrow, that's where this secondary fracture line is. This is a depression fracture. because the secondary fracture line comes out along this top surface of the calcaneus. In the case of a depression fracture, the second pin goes above the first pin. X marks the spot. As opposed to a tongue fracture, where the secondary fracture line comes out along the vertical wall of the posterior tuberosity. In that case, the second pin goes below the first pin. Again, X marks the spot. If you happen to put the second pin in a tongue fracture above, there's a very real chance that that second pin will go into this tongue fragment, and you'll never be able to get subtalar distraction like you desire. You'll just be moving the tongue fragment rather than distracting the subtalar joint, and you'll just be fighting that the entire case. Point 6. So a lot of times you'll have a fracture of the anterior fragment of the calcaneus. Our French colleagues never fix that anterior fragment. That might be a little bit foreign to our American surgeons. But the reason our French colleagues don't do that is because, again, when they distract the subtalar joint, it produces a taxis of the calcaneocuboid ligament with a net resulting compressive force on the anterior ligament, on the anterior fragment. Let's see if I missed that. Okay, so here we are. Here's the calcaneus right here. And let's say there's a fracture right here. And here's the cuboid bone. And here's the talus. So we got talus, calcaneus, cuboid. Sometimes there is a fragment, a fracture line right here on the anterior part of the calcaneus. And our French colleagues don't fix that. They rely on distracting the subtalar joint. And when you do that, you actually get two vectors that are shown in green. So the red line represents the distraction. The green lines represent the net other forces as a result of the distraction. And it puts a compressive force on this fracture line here, and it holds that fragment still. So our French colleagues would say that fixation of that anterior fragment is not necessary. They point to this published paper by Galeno, but I'm going to suggest to you it's not worth arguing the point. If you meet resistance from your surgeon and they want to fix it, let them go ahead and fix that anterior fragment any way they desire. It will not have an adverse effect on calcaneal. Point 7. Next time you've got a calcaneal sample in your hand, take a good look at it. I'm showing you the medial side of the nail, where the hole is a D hole, as opposed to the lateral side of the nail, where it's a full circle. It's a D hole because this allows the screws to thread through these medial D holes, providing angular stability and preventing screw back out. It also allows our screws to act as a lag screw, and I'll explain that in a second. Actually, I'll explain that now. So here is a calcaneal fracture. This is an axial view, and my mouse arrow is showing the fracture line here. So we have a big medial fragment here and a big lateral fragment here. Normally, we recommend that the screw head rest against the lateral wall of the calcaneus, as shown in the bottom screw of the picture on the left. However, if you bury the screw head, as it is in the top screw, below the cortical wall and bring it closer to the nail, it will now lag that medial fragment towards the nail, closing the gap. So that's how we lag the medial fragment to the lateral fragment. And that's why we don't need to temporarily fix these articular fragments. Next point. We need to take care to prevent the hollow reamer from deviating from the axis of the guide pin, like I'm showing in this bottom picture here. So here's the guide pin, and you can see that this hollow reamer is clearly not following the axis of the guide pin. It's either because the pin has become bent, or our starting trajectory is poor. So what do? I'm going to put the onus on every distributor and every sales rep that when you receive an instrument set, one of the first things that you want to do is make sure it's complete, and you want to take out every one of the guide pins and wires, roll it on a flat tabletop, and make sure those pins are rolling true and straight. If they're not, replace them. We are doing the same thing in the Chicago office. Secondly, don't force that first guide pin into place, as this may cause the guide pin to get bent. So under fluoro, make sure the guide pin has not become bent during insertion. If it has, remove it, insert a new guide pin. So the technique for inserting the hollow reamer: insert the hollow reamer just 1 or 2 millimeters, take a fluoro shot. Make sure the hollow reamer is following the trajectory of the guide pin. If it's not, remove the hollow reamer, revise your trajectory. Go a couple more millimeters, take a fluoro shot. If it's remaining true to the guide pin, keep going. Go a couple more millimeters, take a third fluoro shot. If you're happy it's staying aligned with the guide pin, then take it to its proper depth. If at any point it's deviating from the guide pin, back it out and start again. In this case here, if they keep going, they're just going to cut the guide pin in half. And I've been in the case where that happened. And that's not fun. When performing a subtalar arthrodesis, you must perform the tunnel in 2 stages. The first stage is performing the tunnel in the calcaneus, and the second stage is then performing the tunnel in the talus. You don't do it all in one pass. Even when we do sawbones, you'll see that that hollow reamer gets hot, and we want to avoid bone necrosis. We also want to avoid bending of the guide pin. Now, what do you do if there's a varus deformity that needs to be corrected? What you do, and so again, we're doing a subtalar arthrodesis here, but I'm adding the complication that we have a varus deformity that needs to be corrected. So what you do is you insert the 12 millimeter K-wire with stopper. Make sure that it's only engaged in the calcaneus. Now, this may cause the stopper not to be flush with the calcaneal tuberosity. I can tell you that sometime in the near future, we will be introducing into the set a 12 millimeter K-wire with stopper that has a shorter portion that goes into the bone, and it'll be shorter such that it will not engage the talus. The point being that if you push this K-wire all the way in such that it also engages the talus, then when you go to execute the distractor, you're just going to bend that wire. So for now, since the wire is sufficiently long and does engage the talus, if you push it in until the stopper is flush with the calcaneus, just leave the wire stopper short of the calcaneus under fluoro and make sure that the wire is not engaged in the talus. So at that point, you can prepare the calcaneal tunnel with the 12 millimeter hollow reamer. Then you activate the distractor to correct the varus deformity. You complete the intrafocal reduction if desired. Then you reinsert the 12 millimeter K-wire with stopper this time such that the end of the 12 millimeter K-wire is engaged in the talus. Then you're going to reinsert the 12 millimeter hollow reamer back into the tunnel that's been created with in the calcaneus. You'll do that under fluoro to make sure it's following its path. Once you've confirmed that, then you'll prepare the tunnel in the talus. The main point is that if the distractor is going to be used with the K-wire, if the distractor is going to be used, the K-wire cannot be simultaneously engaged in the calcaneus and the talus, or it will bend. When you're doing a subtalar arthrodesis, don't waste your time chasing the bone plug if it's not come out in the hollow reamer from the talus. It will always come out from the calcaneus. More often than not, that bone plug will not come out in the talus, and that's because there's no fracture of the talus, so there's no proximal end. So what you can do is you can try to wiggle the hollow reamer to try to crack it off, and if you can't, just leave it there. It'll engage into the hollow chamber of the nail. But it might present a small complication trying to measure the final length of the arthrodesis nail that you have to put in place, because that plug is there and you need to account for that. So what can you do? Well, you can take the 12 millimeter K-wire and you can use it like a drill, and you can create a pilot hole into that plug under fluoro. You bring the tip of that 12 millimeter K-wire to the position that you determine is the final position for the nail. You do that under fluoro. That's one way to do it. And then you would take this depth gauge, and that pilot tip of the depth gauge would fit into the pilot hole that you've just prepared in the residual bone plug. Another way to do it is to take one of the small diameter K-wires and push it into the periphery that's surrounding the plug that was created by the hollow reamer. Push it in under fluoro up to the subchondral surface. Take a pair of hemostats, put it on the end, flush with the calcaneal posterior tuberosity, take it out, and take a measurement. Those are two ways to get your final arthrodesis nail length. So positioning of that arthrodesis nail. Don't be too vertical with its positioning, because if you are, the most proximal screw can likely interfere with the fibula. So a good position is with the nail passing through the sinus tarsi. So here's the sinus tarsi right here. So notice you're not going right towards the dome of the talus. It's much more horizontal than that. Okay, you're going to this point out here, more like 2 o'clock, 2:30. Now, if by chance the tailor screw, okay, so here's the tailor screw here where my arrow is. This is where that most proximal screw would be. And you see that it would interfere with the fibula. So if it's going to interfere with the fibula, then simply what you do is just rotate the nail so that the screw hole is now oblique in the lateral view. And now the trajectory of the screw is a bit more anterior to posterior rather than just a true lateral to medial. That too will help you avoid the fibula. It means the other two screws then will also be going a bit more anterior to posterior, and that's okay. Now, the slot in the nail serves multiple purposes. It's great for putting the bone plug such that the bone plug covers the slot, because that's where you're going to get your best bone bridging. But it's also a place where you could put a screw, a really long screw, if you need to stabilize other fragments. For example, in the case of a tongue fracture, you might want to put a screw in from the top surface down to the inferior part of the calcaneal tuberosity. Now, these long screws are currently not available in the Calcanail set. You would have to use long screws from, let's say, a Synthi set. But in the next couple months, these long screws should be available to you, up to 80 millimeters in length. And there will soon, and for now, you'll just use a freehand technique to place that screw. Ultimately, we will be providing a new alignment guide for that, for placing the screws both lateral to medial and through the slot. Point 11. Where is the end of the nail? I have no idea where the end of the nail is and where the handle starts. So credit and kudos to Brian Mack for figuring out something so simple. All you do is loosen the nail connector, loosen this screw right here, one full turn, and then pull back on the T-handle to create separation. And now you can see the separation under fluoro, and now you can see that this nail is not all the way in the calcaneal tuberosity. So again, just unthread the screw, one full turn, pull back on the T-handle, and now you can see where the end of the nail is under fluoro. During training and in the training PowerPoint presentation, I've made reference to the Goldbach height index, and I really never explained what it was. It's a nice little index that you can use to see if you have actually restored the anatomical height of the posterior facet. And it directly correlates with the AOFAS score. So what is it? So this is an anterior view of the calcaneus. It's as if I was the cuboid bone looking back at the calcaneus. This is the left calcaneus. So here's where the cuboid articulates. Here's the posterior facet, number 1. Number 2 is the middle facet, and in this area, number 3 is the sustentaculum. So this is the medial side, this is the lateral side. In a normal calcaneus, A and B are of equal heights, and A divided by B equals 1. So in our published study, preoperatively, the Goldbach index was 0.4, meaning that the posterior facet was crushed into the body of the calcaneus, and A divided by B was 0.4. Post-op, after the anatomical reduction, the Goldbach index average was 0.9, the mean range from 0.8 to 1.0. I would say that's a terrific outcome. We restored anatomical height. Fuzzy picture with a lot of information, but I'm going to reduce very simply. An arthrodesis, you can have the greatest hardware in the world, but a fusion, the success of a fusion is based on the volume of bone graft you can put in that site. And that's what this published study is showing here. So they've looked at fusions at the ankle, the subtalar joint, which is the one that we're going to focus on, at the calcaneal cuboid joint, and at the talar navicular joint. Here's the number of patients that have been studied for each one of those fusion sites. And here's the type of graft material that was used in those fusion sites. So we have autograft versus PDGF and tricalcium phosphate. So let's look at the row that's labeled subtalar. There's a study on 203 patients. Now, this column here talks about the quality of the fusion when adequate graft material was used. The definition of adequate graft material is when bone graft fills 50% more of the available fusion space at 9 weeks. So, if we look at this first column here, the success rate of the fusion was 84% when adequate bone graft was used. In contrast to only 21% successful fusions when less than adequate bone graft was used. So that is a 63% difference in the fusion rate. It speaks to the point of having adequate bone graft or any graft material in the fusion space. Well, Calcanail is a wonderful tool for that, because when we create the tunnels in the calcaneus, in the talus, and we can also use the 10 millimeter hollow reamer to create debridement of the subtalar joint and more bone plugs, we can use all of that bone graft material primarily to fill the subtalar joint, and if there's any left over, pack it into the hollow nail. So now I'm going to go over the most recent published paper as continuing clinical evidence for good clinical outcomes with Calcanail. So this one was published by our Polish surgeon friend, Dr. Fallis. It's a single-center prospective study. The average age of the patients is 47 years, ranging from 22 to 68. There were 17 patients with 18 fractures, so obviously one patient had a bilateral fracture. Pre-op, the average Böhler angle was -3, ranging from -5 to 20. And we know that we're trying to get a Böhler angle restored to 25 to 40 degrees. That's what's normal. Time to surgery from initial injury was 6 days, pretty quick, ranging from 3 to 14, so much quicker than an ORIF with a lateral extensile incision. The French and our European colleagues use a different classification system. It's a modification of the Sanders classification. It's called the UFISA classification system, but I've correlated it for you. So there were 10 Sanders type 2s. There was 1 Sanders type 3 and 4 Sanders type 4, which is a common knee fracture. Let's look at the results. Average follow-up at 1 year, ranging from 6 to 18 months. The average Böhler angle was restored to 29 degrees. We know that 20 to 40 is considered normal, so that's a good result. The American Orthopedic and Ankle Society ankle hindfoot scoring system is based on 100 points. Our average was 82, ranging from 55 to 100. Nearly 67% of our patients had a good or very good outcome. Pain score is based on 40, our average was 30. Function score is based on 50, our average was 44. Our foot loading score is based on 10, our average was 8. And using a visual analog scale for pain, based on our average score was 2.5, so we had 6 patients with no pain, 4 with mild pain, and we had 8 with either moderate or continuous pain. The quality of the reduction, this is what's so important, 89% of our patients had a near anatomical or anatomical reduction. Only 1 was unsatisfactory and 1 was just incorrect. And here's the incredulous statement that we continue to make. No wound healing problems, no infections, no wound diseases, no wound breakdown, no infection. We do have complications, they're minor. We had 2 patients with local pain in the area of the distal screw. 1 implant was removed after 8 months. So what's the take-home message? At an average of 1 year follow-up, no wound healing or infectious problems. 67% of our fractures had a very good or good AOFAS score. 89% of the fractures had an anatomical or near anatomical reduction. These results are comparable to those published by Goldzak et al. In the first publication, indicating that these clinical outcomes are extremely reproducible. You should know that Dr. Fallis is not one of the surgeon inventors on Calcanail. He's an independent and just is really happy with his results using Calcanail. And it's interesting that his results are comparable, if not identical, to what Goldzak and Simone published. Here's another great selling point for Calcanail compared to an ORIF. This is on a fracture, not an arthrodesis. By 6 weeks with Calcanail, the patients are in a normal shoe, walking, and beginning subtalar physical therapy. Contrast that to with an ORIF, they don't begin physical therapy, and they're non-weight bearing for 3 months. So it's not until they get to 15 weeks that they begin to be non-weight bearing and begin physical therapy. It's a huge improvement on patient independence and post-op therapy. So what do we have for you for sales support and surgeon education? I believe you all have already received clear models. This is a clear model of the fracture on the right, the arthrodesis on the left. For the doctors, it comes on a stand. And for you all, it just comes as samples that you can put in your bag and take out whenever you want. If you want a stand, you can order it. I think all of you have also received functional plastic samples of both the fracture nail and the arthrodesis nail, and 3 different lengths of screws. If you haven't received it, contact your regional manager. And soon, you'll be able to work with what we're calling the Calcanail Ortho Trainer. It's going to be a much easier and more representative of actual surgery for teaching the doctors how to use Calcanail. So the bones in this Ortho Trainer are actually radio opaque. If you have access to a fluoro unit, you'll be able to do the whole procedure under fluoro. If you don't have access to a fluoro unit, you can take off these lateral and medial skin flaps, and you can see what you're doing. So the way this will work is there's already a fibula and a tibia in here. There's already a forefoot in here, and the talus and the calcaneus are modular. They'll have a Sanders 2C fracture. They'll have ligaments in place, and you'll be able to just put in a fresh one, do the procedure. I would suggest you do this sawbone with metal samples. Then you'll take out the calcaneus and talus, put in a fresh one, and with the one you just did the procedure on, my suggestion would be you take out the metal parts and replace it with your plastic samples, and give it to the doctor as a leave behind, so he can witness what he just did. Okay, Greg, at this point, we can take everybody off mute. We can see what questions we have. And if you have questions, why don't you type them in the chat box area there? Greg, can you hear me?
Yep, I can hear you.
Okay, good.
Just by way of summary, just and put your questions in the chat box and I'll read them off. But just remember, all of this information is going to be on the Dropbox, and you have access to the Dropbox. Take the test that is there, take it off the Dropbox, send the test to me at g.sherburn@fhortho.com. Put in the name of 3 doctor targets that you're going to go after. And then I'll get your test back, I'll check it, and get your names, and I'll send you a $10 gift card for Starbucks. If you don't have samples, put them on the test or call your regional manager. We'll get you samples out ASAP. Now, a couple of questions, Mike. Mark, your question is, what is the average length of surgery time?
It's less than an hour. So if you go back, I'm trying to open this presentation right now, the training presentation that we did on Calcanail, where I summarized the first published paper that we have. It speaks to what their average time was in surgery. I'm opening that right now, and I'll give you a very specific answer. And
okay. Also, Mike, Phil Gritsmaker had a question. Are the D holes, the final position, are they on the lateral or the medial side?
they're on the medial side.
The D holes are on the medial side.
Oh, wait. Now you got me confused.
Well, if they're going to lag, you go in through the lateral.
It's on the medial side.
They're on the medial side.
Yeah.
Don't the screws go in on the lateral side?
Yes.
So wouldn't they be on the lateral side?
No, the full circle's on the lateral side.
Okay. Okay. All right. Mark, ideal prospect, fellowship trained foot and ankle ortho or trauma specialist? Mark, the answer to that is yes. We have both fellowship trained ankle and foot and ankle surgeons, and also the trauma surgeons who deal with this are also a target. In France, the designers of this product are trauma surgeons. Now, we also have a fairly good size podiatry group for the surgical podiatrists who have this. But I would say a foot and ankle trained doctor or a traumatologist are both prospects.
Let's go back to this D-hole. I want to clarify something here. When we teach how that T-handle needs to be assembled to the calcanail, we teach that the ball on the T goes on the same side as the D-hole. And the ball is to be on the medial side, pointing medially, because the alignment arm can only slide on the non-ball side of the T-handle. So,
He's right. Yeah.
When you assemble the T-handle to the nail, you teach the scrub tech that you put the ball side of the T on the same side as the D hole of the nail. That's the medial side, because the ball needs to be pointing medially.
All right, good. Any other questions? Ask out, because I would like to keep this under an hour. We are still under an hour. I want to again reiterate, I appreciate your participation in this. Now we will have another webinar. Hopefully you can all attend to that one. That will be, and I'm sorry, that was February 23rd, Mike, was that right?
I think. Yeah, I'm pretty sure.
I'm pretty sure we'll send something out for you, but that one was going to be on the CoLS. And so we will do that, and then we'll have another one in March on the Arrow shoulder. So that will be our schedule of webinars, and Mike will be leading those. And Mike, I apologize.
Yeah, I can confirm that the next one is absolutely February 23rd, like you said. And then the next one after that is
March 22nd.
Really?
Well, let me check.
No, it's the 23rd.
23rd, yeah, March 23rd.
Yeah.
Okay. And Mike will do that. Okay. I have a couple more questions, Mike. Greg Cardenia asked, in the technique guide, it looks like the D hole is on the lateral side.
Yeah, if you look at figure 9B of the technique, it looks like the D looks like it's on the lateral side. I don't know if that's a mistake or not, but if you look, like I said, figure 9B of the technique guide.
Well, let's just look at that.
And Doug Sender asks if we have a copy of the recording. Yes, there will be a copy of the recording, and we'll send out how you can it'll be on either Dropbox or on our website, and we will get that to you, Doug, tomorrow. The average surgery time, again, from John, the average surgery time is an hour or less. Now, that may not be the first surgery. The first surgery can run a little bit long, but after they've done 2 or 3, it is certainly an hour or less.
Yeah, so, sorry, Fergie. I think that's an illusion. Take a look at figure 8C. You'll see that's a view from the. We got 2 different things there. Okay. Figure 8C in the gray silhouette is a full circle, but the green inset is the D hole, but that's showing it from the medial side. I promise you. So if you look at figure 9A, you'll see that the ball side of the T is on the medial side. And I promise you that's the same side as the D hole.
Yeah, look at figure 9B. That's the lateral side and it clearly shows the D.
I don't see a D. I think that's an illusion.
9B as in boy.
I hear you.
Look at the
okay, but Greg, even if it does show it that way, don't get hung up with that.
Okay.
I'm teaching you the ball side of the T goes on the D hole side of the nail, and the ball side has to go medial. It's as simple as that.
Yeah. Okay.
One other comment. Now, obviously, we're blessed with a resource in Mike Kaufman that we really want to make use of. I'm going to ask you and tell you that Mike is going to be available for a lot of first-time surgeries that whenever possible he will try to get to help you, or the regional manager from FH will be there for the surgery. Now, please coordinate that type of request for Mike or regional manager's participation in your first surgery for a customer through your regional manager. I'm going to ask you not to go to Mike directly. Let me take care of that through the regional managers.
So, John Ashley, the answer to the question on the average time of surgery is less than an hour.
Less than an hour.
Yep.
Okay. Thank you all very much. I appreciate your effort. Mike Kaufman, again, thank you very much. We had an outstanding participation with everybody. I think this information is great to help you sell this. I would love you all to identify 3 surgeons to go after in the next week or 2 and let me know how we can help you. Send me an email with your test and your surgeons. And if you need samples, we will be, we've got them. We'll be happy to get them out to you. Thank you all. I appreciate it. Mike.
Good luck, everybody.
Bye.
Yep.
Thanks,
Bye.
John. Bye. Super.